This portion of CardioSource Video News is supported by the makers of Xarelto.
Welcome to the second day of ACC 12. I'm Dr. Randy Martin with CardioSource Video News, and we've got a stellar panel, hopefully a super stellar panel to talk about the late-breaking clinical trials. Let me introduce, on my immediate left is Dr. Peter Block. Peter is professor of medicine and the director of the structural heart program at Emory University Hospital in Atlanta. Dr. Athena Pappas. Athena is associate professor at the Brown Medical School and the director of the Echo Lab at Rhode Island Hospital. And Dr. Tony DeMaria, who's professor of medicine at the University of California in San Diego. And as many of you know, Tony does a great job as editor-in-chief of the Journal of the American College of Cardiology. So thank you all for joining us. So, you know, we've got a lot of trials. What's piques your interest this morning?
Well, let me start out with INFUSE-AMI, which is a trial that Greg Stone presented. The bottom line of this trial, it's a complex trial. Bottom line, it asks two questions. Giving intracoronary apixaban versus no apixaban, and this is through a balloon that weeps apixaban into the area of the thrombus, and aspiration versus no aspiration in acute anterior MI. The bottom line here is that it turns out that aspiration doesn't seem to make very much difference at all, and apixaban may make some difference in infarct size. Endpoint here is infarct size,
right,
not anything
right,
else.
Right.
But there's a 2% overall difference in infarct size, which translates into zero clinical effect. For me, I think this trial says it probably doesn't make any difference, and this balloon apixaban business may or may not be okay. There are some previous trials that seem to have shown that 2B3A inhibitors given intracoronary may reduce infarct size. I think that's still open to question. And so overall, I would say this trial is okay. Greg is terrific at the end. He says, well, it is a p-value that's significant, but it's a modest change. I would say it's almost no change.
Athena?
Well, I guess the question is, would a soft endpoint translate into real hard endpoints and major adverse events? It was a small trial, 450 patients, and so it would need a large randomized trial, and really given the other things we have in our armamentarium, if it's worth it. I think the other issue is that you have to put multiple catheters down there, and so I'm not an interventionalist, but that carries some risk. And I think the other piece of it that was interesting is that thrombectomy didn't seem to make a difference in infarct size. So Peter, do you think you're going to still use thrombectomy?
Well, you know, we do, and I think that has to do more with the technique of how you do it in somebody that has a big thrombus burden. Do you want to try and get rid of that? It still makes sense because if you dump that downstream rather than get it out, it can't be good for you. That's sort of the sense. I think we don't really know all those answers, and there's still a lot to be learned here. But for this trial right now, it probably will generate more trials.
Tony, comments?
Well, I think this is kind of a classic example of something that may be statistically significant, but biologically not so relevant. If it takes 6,000 patients to make an absolute difference of 2% in a measurement of infarct size by MRI that is hardly precise, then you wonder. I think the other aspect of this is that you know, all of us as physicians see patients with large MIs.
Right.
And those patients who come in with Q waves, ST segment elevation everywhere. And that's the group of patients where this kind of incremental benefit might be of value. Same thing with thrombectomy. If there's a huge clot burden, and it's reasonable to believe you're going to benefit. And if you don't see much clot, then I don't see personally any point in instrumenting the patient.
Okay, let's switch from this trial. Give me another trial that caught your attention this morning.
Well, the BRIDGE trial was an interesting trial. It's one of those studies that's trying to increase the quality of care by adherence to guidelines measures. And it was done in Brazil. And the idea was to take nurse coordinators and have them have checklists and then go over the patient's records, and if there was some part of that patient's treatment that wasn't according to guidelines, to prompt the physician. Now, shockingly, more of the physicians who were prompted actually
did
changed.
something. That's amazing.
I never would have thought.
I was flabbergasted at that.
But I think the interesting aspect of this is that there's this concept in medicine that maybe we should be more like airline pilots. You know, airline pilots have these lists and they go time after time. If they've flown 1,000 flights, they still go through the same checklist. And there may be some role for that in medicine. Even the best of us probably forget from time to time.
Even the best of us, is that right? So Athena, what do you think about this?
Well, I would agree. It does seem to sort of prove the obvious, but I think we're seeing more and more that it takes a team approach. And using nurses and other physician's assistants really plays a big role, both in heart failure and in a lot of other arenas. So that was sort of my take-home message.
I mean, is this a role for computers to do this for you? And you know, I mean, well, I think the nurses were certainly more effective, but are we going to transition to that?
I think the answer is that if you have somebody prompting you, it's probably a pretty good thing. Docs tend to be a little bit arrogant about saying, I don't know why I would say that, but you know, they look at a computer and say, well, I've done that, I don't have to worry. Right. Whereas if you have a team approach and somebody comes up and says, hey, you forgot to do this, it's not a bad thing. And I think there is a lesson to be learned from this trial.
That's good.
It's important because these quality metrics we're going to be judged on,
Absolutely.
both as individuals, as groups, and as hospitals. So finding ways, whether electronic medical records or individuals, to put this in place is important.
Yeah, and you know, the simple fact of the matter is the minute a physician knows that somebody's watching their behavior, just participating in the trial and knowing that that's happening, then you change your behavior a little bit. So, I think everyone would agree that patients do better if they receive guideline therapy, and any measure that can be implemented to help that would be beneficial.
Okay, well, 2 great studies, and we're going to have more for you after a short break, so stay tuned.